Thyroid function. So an overview of the thyroid gland. So the thyroid gland is a butterfly-shaped organ. It is located in the lower anterior neck, just below the larynx and in front of the trachea. It consists of two lobes, right and left, and it's connected by a thin isthmus. The thyroid gland contains two main types of cells. It has follicular cells. These cells form spherical follicles filled with colloid, which contains thyroglobulin. Their function is to synthesize and secrete thyroid hormones such as thyroxine, which is T4, and triiodothyronine, which is T3. These hormones help regulate metabolism, growth, and development. T3 is the more active form. T4 is a precursor that is converted to T3 in the peripheral tissues. And then we have the parafollicular cells, which is also known as C cells. These are located in the spaces between the follicles. Their function is to produce calcitonin. Calcitonin is a hormone involved in the calcium homeostasis. It also helps lower blood calcium levels by inhibiting bone resorption, promoting calcium deposition in bones. Calcitonin is especially important during periods of rapid bone turnover, like when children are growing or when someone is pregnant. The parathyroid glands, those are basically four small glands. They're located on the posterior surface of the thyroid gland. Usually there's two on each lobe. Despite their proximity, the parathyroids are functionally distant. So they secrete parathyroid hormone, or PTH. The role of PTH is that it helps regulate calcium and phosphate balance in the body. It increases blood calcium levels by stimulating bone resorption, increasing calcium reabsorption in the kidneys, and enhancing vitamin D activation by an increased calcium absorption from the gut. It can also decrease phosphate levels, and it does that by promoting renal excretion. Thyroid hormones. So we have iodine. Iodine is the most essential element for the synthesis of thyroid hormones. The thyroid gland actively absorbs iodine from the bloodstream, and that helps to produce T3, which contains 3 iodine atoms, and T4, which actually has 4 iodine atoms. So without sufficient iodine, the thyroid hormone production will drop, and that could cause a goiter or cause hypothyroidism. Storage of T3 and T4 in the thyroid. So these thyroid hormones are not stored in vesicles like many other hormones. Instead, they are stored extracellularly in the colloid of the thyroid follicles. The storage form is a large protein called thyroglobulin, which contains inactive T3 and T4 molecules. So basically, this unique storage mechanism helps allow the thyroid to maintain hormone supply for several weeks. Secreting into the bloodstream when stimulated by TSH, which is the thyroid stimulating hormone from the pituitary. T3 and T4 are cleaved from the thyroglobulin. They are then secreted directly into the bloodstream. T4 is more abundant than T3 in the bloodstream. The T4 concentration is usually about 50 times higher than that of the T3. However, T3 is the more active hormone. So conversion of T4 to T3, about 80% of T3 in the body is produced by the peripheral conversion from T4. This occurs mainly in the liver and kidneys by removing one iodine atom from T4. This conversion is vital because T3 has 4 to 5 times the biological activity of T4. So transport of those thyroid hormones in the blood, both T3 and T4 are lipid soluble, so they require carrier proteins for transport in the blood. Over 99% of circulating T3 and T4 is protein bound. Only free or unbound hormone is biologically active. T3 has a shorter half-life and lower protein binding than T4. Thyroid hormones, T3 and T4, circulate in the bloodstream, which is bound to specific transport proteins that can help maintain their stability and regulate their availability to tissues. The primary carrier of both T3 and T4 is thyroxine binding globulin, or TBG. This binds the majority of these hormones with high affinity. Transthyretin, also known as prealbumin, binds T4 with moderate affinity and plays a secondary role in the transport. And then we have albumin, which is the most abundant plasma protein. It will bind both T3 and T4, but it does it with low affinity. So despite weaker binding, albumin contributes to the overall hormone pool due to its high concentration in the blood. Only the unbound or free hormone is biologically active and able to enter cells to exert metabolic effects. Thyroid hormone bonding. So once again, usually only about 1/3 of the binding sites on thyroid hormone transport proteins like thyroxine binding globulin, albumin, etc. are occupied at any time. This reserve helps maintain stable hormone levels in the bloodstream, even if production or release fluctuates. Only the free or unbound fractions of thyroid hormones, so free T3 and free T4, are physiologically active, as mentioned before. These free hormones can enter target cells and initiate biological effects. So once again, T3 is the most biologically active thyroid hormone, being approximately 3 to 4 times more potent than T4. Although T4 is produced in greater quantities, much of its effect comes from the peripheral conversion into T3. So major actions of these thyroid hormones. So they have a part in the regulation of metabolism. So the carbohydrates will increase glucose absorption and utilization, stimulate gluconeogenesis and glycogenolysis. Proteins will promote protein synthesis and degradation, important for growth and repair. And then we have lipids. They enhance lipolysis and cholesterol metabolism, which will contribute to the energy balance. And then we also have, they play a part in the central nervous system or CNS activity. So it helps to promote normal brain development in fetuses and infants. It will also influence alertness, reflexes, and overall cognitive function in adults. They also have a part in the cardiovascular stimulation, so it can increase heart rate and cardiac output. It can also enhance sensitivity of the heart to catecholamines like adrenaline. They also play a part in bone and tissue growth and development. So they will stimulate bone turnover and growth, and it is also essential for normal skeletal development during childhood. They also play a part in your GI regulation or gastrointestinal regulation. They can help increase motility and digestive enzyme secretion, aiding digestion and nutrient absorption. Also can help with sexual maturation. It can influence reproductive system development and function, and they can also, the thyroid imbalances can affect menstrual cycles and fertility. So regulation of these thyroid hormone production. So the hypothalamus plays a key role in controlling thyroid function by releasing the thyrotropin releasing hormone, or the TRH. The TRH acts on the anterior pituitary gland, which stimulates it to secrete thyroid stimulating hormone, or TSH. TSH then acts on the thyroid gland, promoting the production and secretion of the thyroid hormones, T4 and T3. We also have some negative feedback control. So this system operates via a negative feedback loop to maintain hormone levels within a normal range. So when blood levels of T4 and T3 rise to adequate or high levels, they signal back to the pituitary gland and hypothalamus to reduce the secretion of TSH and TRH. This feedback will help shut down further production of TSH and TRH, which in turn will reduce the stimulation of the thyroid gland and will, in turn decrease the hormone secretion. So an example I have here is if a patient's blood level of T4 and T3 fall below normal or hypothyroidism, the hypothalamus will respond by increasing TRH release, which leads to the increased TSH from the pituitary and stimulation of the thyroid gland to produce more hormones. So conversely, if thyroid hormone levels are too high, hypothyroidism, or hyperthyroidism, TRH and TSH secretion are suppressed to reduce that thyroid hormone production. TSH, like we mentioned earlier, it plays a crucial role in regulating the function and structure of the thyroid gland. One of its primary actions is to stimulate the thyroid gland to uptake iodine from the bloodstream. Iodine is an essential element required for the synthesis of thyroid hormones T3 and T4. In addition to promoting iodine uptake, TSH also increases both the size and number of follicular cells in the thyroid gland. This process is called thyroid hypertrophy and hyperplasia. So why this matters? By increasing the follicular cell size and number, TSH enhances the thyroid gland's capacity to produce and secrete hormones in response to the body's need. So basically, this adaptive response helps to ensure that during periods of increased demand, like times when there's iodine deficiency or increased metabolic requirements, the thyroid can ramp up hormone production. So an example, so in cases of iodine deficiency, increased TSH levels lead to thyroid enlargement, commonly known as a goiter. So due to hypertrophy and hyperplasia of the follicular cells, trying to compensate for low iodine availability. Some assays for thyroid function that we can use. We have the initial thyroid function testing, typically begins with a high sensitivity TSH test. This test is highly sensitive and can detect even subtle changes in the thyroid function. So this makes it a pretty reliable screening tool. We can also measure serum for total T4 and T3 levels, and this is usually done by a radioimmunoassay technique. These tests measure the combined amount of hormone, both bound to proteins and the free part that's also bound or free in the blood. So, however, changes or abnormalities in thyroid hormone binding proteins, such as thyroxine binding globulin or the TBG, albumin or transthyretin, can cause abnormal total T4 and T3 levels, even when thyroid function is normal. So, for example, pregnancy or certain medications can alter binding protein levels, and that can mislead the total hormone measurements. Therefore, it is essential to measure the free or unbound T4 and T3 levels, as these represent the biologically active forms of the hormone that are available to tissues and responsible for the physiological effects. Specimen collection for thyroid testing. So blood samples for thyroid function tests should be collected in a clot tube with a serum separator tube, which is an SST. This is the preferred choice for testing. Proper sample handling is essential, obviously, for the integrity of the specimen. Samples can be refrigerated for up to 24 hours if immediate testing is not possible. For longer storage, if it can't be tested within that 24 hours, samples should be frozen, and then that will actually preserve the stability for up to 30 days. It's important to avoid lipemia and hemolysis in these samples, as these conditions can interfere with test accuracy and could lead to unreliable results. Thyroglobulin. So this is a large protein synthesized and secreted by thyroid follicular cells. It serves as a precursor and storage form for thyroid hormones within the thyroid gland. Measurement of thyroglobulin in the blood is important for monitoring certain thyroid diseases like thyroid cancer and thyroiditis. Thyroglobulin levels are measured using immunoassays like a double antibody radioimmunoassay or an ELISA, an enzyme-linked immunosorbent assay. You can also use immunoradiometric assays and immunochemiluminescent assays. The accuracy of these assays depends heavily on the specificity of the antibodies that are being used and the absence of interfering substances, particularly anti-thyroglobulin autoantibodies. So because anti-thyroglobulin autoantibodies can interfere with the assay and produce falsely low or high results, it is critical to screen for these autoantibodies whenever thyroglobulin is measured. So radioactive iodine uptake test. This test is a nuclear medicine evaluation, and it's used to assess thyroid gland function. In this procedure, a small dose of radioactive iodine, usually the I-123 or I-131, is going to be administered orally to the patient. The thyroid gland selectively takes up iodine to synthesize thyroid hormones. The test will measure the percentage of the radioactive iodine dose that is absorbed or taken up by the thyroid gland over a specified period of time. This percentage is called the radioactive iodine uptake value. So a high uptake of radioactive iodine indicates that the thyroid gland is metabolically active and is producing increased amounts of thyroid hormones. And this can be seen in things or diseases or conditions such as Graves' disease or toxic multinodular goiters. A low uptake will suggest that the thyroid gland is metabolically inactive or suppressed, which can occur in conditions like thyroiditis or excess iodine intake. So measured free T4, the direct measurement of free T4 is considered a better indicator of thyroid status in patients who have extreme abnormalities in thyroid hormone binding proteins. In conditions such as pregnancy, liver disease, nephrotic syndrome, or when patients are taking certain medications, the levels of binding proteins can fluctuate, making total T4 measurements unreliable. So to accurately assess thyroid function in these cases, automated immunoassays using labeled T4 molecules have been developed. These assays can specifically measure the free or unbound T4 fraction, which is the biologically active form of the hormone. TSH, or high sensitivity TSH. High sensitivity TSH is a test that's considered the first and best laboratory test for detecting thyroid abnormalities. It is highly sensitive to changes in the thyroid hormone levels, which makes it the preferred screening tool. In cases of subclinical hyperthyroidism or subclinical hypothyroidism, patients often present with an abnormal TSH levels while their total T4 or free T4 levels remain within the normal range. This means that the TSH can detect thyroid dysfunction earlier than hormone measurements alone. The most commonly used high sensitivity TSH techniques employ immunometric assays that utilize 2 or 3 monoclonal antibodies for high specificity and accuracy. These assays are designed to detect even low concentrations of TSH in the blood. So thyroid disorders, we'll start with hypothyroidism. This is characterized by low levels of thyroid hormones, T3 and T4, in the body. This leads to a decreased metabolic rate and a variety of clinical symptoms. It affects females about 4 times more frequently than males, making women the predominant group that's going to be impacted by this. We also have congenital hypothyroidism. This occurs approximately in 1 in every 4,000 births, and if it's untreated, it can lead to severe developmental delays and growth issues. So common symptoms of hypothyroidism is we can see an enlargement of the thyroid gland, also called a goiter. It could be present depending on the cause, not always there. We can also see some cognitive impairment, including memory problems and difficulty concentrating, fatigue and general weakness, slowing of mental and physical performance with patients often feeling kind of sluggish, intolerance to cold due to decreased heat production, decreased sweating, easy bruising because of altered coagulation factors. Associated metabolic and cardiovascular risk as well. So hyperthyroidism is linked to increased levels of cholesterol, low density lipoproteins, that LDL, and other lipoproteins as well. These lipid abnormalities can contribute to a higher risk of coronary heart disease in patients that have hypothyroidism. Hashimoto's thyroiditis. This is the most common cause of primary hypothyroidism, especially in adults. It typically has a peak incidence in individuals in their 60s, although it could occur at any age. Patients with Hashimoto's thyroiditis may be euthyroid or have a normal thyroid function or have a hypothyroid, depending on the stage of the disease and the extent of the thyroid damage. The thyroid gland will undergo massive infiltration by lymphocytes, which are the immune cells involved in inflammation. In addition to the lymphocytes, plasma cells are abundant in the thyroid tissue and can contribute to an increase in connective tissue, which can lead to the gland fibrosis and enlargement. This disease is considered autoimmune in nature, with the production of autoantibodies that attack and destroy thyroid tissue, impairing its ability to produce thyroid hormones. Some lab findings that we would see on our side for hypothyroidism. So at the onset, so at the beginning of hypothyroidism, there is generally an increase in TSH as the pituitary gland attempts to stimulate the failing thyroid gland. Levels of free thyroxine index and free T4 are decreased, reflecting reduced thyroid hormone production. Presence of anti-thyroglobulin antibodies also indicates an autoimmune process. This is commonly seen in Hashimoto's. Secondary hypothyroidism is due to pituitary dysfunction. So this is where you'll have both the TSH and the thyroid hormone levels, T4 and T3, are all going to be decreased because the pituitary is failing to produce the sufficient TSH. So to To differentiate secondary hypothyroidism from tertiary hypothyroidism, a TRH stimulation test can be performed. So in secondary hypothyroidism, the pituitary, as mentioned, is unresponsive and shows little or no TSH increase after the TRH administration. In TRH hypothyroidism, the pituitary will respond to TRH, and that will increase the TSH release. For treatment and diagnosis, so the treatment for hypothyroidism is generally an administration of L-thyroxine, which is a synthetic T4, and that is to try to help restore normal hormone levels. The best diagnostic test for autoimmune thyroid disease is the thyroid peroxidase antibody assay, and this has a really high sensitivity and specificity for this. Hyperthyroidism. This is thyrotoxicosis. It refers to a clinical syndrome caused by excessive circulating levels of T3 and T4 in the bloodstream. It encompasses a group of syndrome characterized by symptoms resulting from elevated free thyroid hormones, which can lead to increased metabolism and hyperactivity of various body systems. The most common cause of thyrotoxicosis is Graves' disease, also known as diffuse toxic goiter. This is an autoimmune disorder that stimulates the thyroid gland to produce excessive hormones. Graves' disease occurs about 6 times more frequently in women than men, and it'll typically present in or exacerbate during times of hormonal change or stress, such as during puberty, pregnancy, menopause, or even after severe emotional or physical stress. So Graves' disease, like I mentioned earlier, is an autoimmune disorder. This is characterized by the presence of TSH receptor autoantibodies in about 95% of patients. These autoantibodies will stimulate the thyroid gland and it will produce excessive thyroid hormones. Some clinical features, they will have a diffuse thyrotoxic goiter, which is an enlarged, a smooth, and firm thyroid gland due to overactivity. A lot of times they will also exhibit bulging eyes, and this is resulting from inflammation and tissue swelling from behind the eyes. Can also have pretibial myxedema, which presents as localized thickening and swelling of the skin over the shins, and this is caused by glucosaminoglycan deposition. Laboratory findings indicative of hyperthyroidism, so they will have a decreased serum TSH due to negative feedback from high thyroid hormone levels, but they will have an increased free T4 and or free T3 levels, and that is reflecting the overproduction of thyroid hormones by the thyroid gland. Treatment of Graves' disease it focuses really on lowering that elevated thyroid hormone level to try to help relieve symptoms and prevent any further complications. The main treatment options are going to be anti-thyroid medication, which reduces hormone synthesis by the thyroid gland. Also, radioactive iodine ablation, which involves administering radioactive iodine orally to try to destroy that overactive thyroid tissue. Can also do thyroidectomy. This is the surgical removal of part or all of the thyroid gland. This is less commonly used, but can be used in certain cases. So currently, the radioactive iodine therapy is the most popular treatment option due to its effectiveness and non-invasive nature. A common outcome of radioactive iodine treatment is hypothyroidism, as the thyroid gland is often destroyed beyond the point of normal function. So as a result, patients usually will require a lifelong supplementation with artificial thyroid hormone to maintain normal thyroid hormone levels, and the medication is called levothyroxine.